All right. Hello, everybody. I apologize about the delay. I looked back and my last video was December, which, I didn't think I'd be spacing it out quite this much, but unfortunately that is what happened. So I'm sorry about that. The next video should not take this long. The subject of this video is going to be that of my third clinical site. So my rotation scheduled, I got it pulled up right here. I spent September and October at Site 1, November at Site 2, December and January at Site 3. Now I did just finish my February and March rotation, so this video is going to be talking about my third clinical site, the December and January. Also, if you hear that clicking noise, those are my dogs. We're walking on hardwood floors with their nails, so please excuse that. There's no way I can get around that for this video. They're very cute, so it is worth it to have them around. So please accept that trade-off for me. Now, so again, this is going to be talking about my December and January rotation site. Now, being that I did just finish my February and March rotation site, the next video should not take this long to come out. So what have you guys missed? Well, so my December and January rotation site was my pediatric rotation. So I went into this program, I was a pediatric anesthesia tech at an outpatient surgery center back where I live. And there, I kind of got a feel for what pediatrics could be like. There was a lot of screaming, a lot of crying, but I could also see that there was a lot of reward to that side of things. So when I originally came into the program, I thought that I might be interested in doing pediatric anesthesia. Then as time went on, learned more, heard from people, saw how different pediatrics would be, and I was incredibly scared to do pediatrics. And I mean, I was terrified. For like the week leading up to doing my pediatric rotation, I hardly slept, and you can ask my wife about that. It was awful. It wasn't necessarily an unfounded fear, because I've kind of been taught that in pediatrics things happen very quickly. You have to just maintain constant vigilance, and if they start to tank, they tank fast, and you have to be very careful. Everything's different. You do twice the amount of work. Those were all things that I'd heard and had terrified me. So to start my rotation, my first day was actually December 1st. Our December rotation was December 1st to 19th, and then we got Christmas off and New Year's off. And then our January one picked up from January 5th to January 30th. So I got a good bit of time there. It was a lot different than I was expecting. I'll put it like that. So this hospital, it is, if I'm not mistaken, it's a level 1 pediatric hospital, level 1 trauma pediatric hospital. And it's the only one in the area for quite a ways in either direction. So it's a lot of traffic comes through this hospital, And I was, knowing that it's a level 1 pediatric and knowing all of the stuff that goes into pediatric, I figured it would be lights out, constantly busy, and just horrifying. And I'm pleased to say that it was not. It was more relaxed. Everybody was incredibly nice, super welcoming. Even the surgeons were understanding if there was delays or you couldn't get an IV. Everybody had this air of understanding, and that the patient is the number one priority, not the clock. And that is one thing that I was not prepared for. In the adult world, again, this is super subjective, I've found that the biggest motivator is money and time, in that patient has to be on the table at this time, and you better work your butt off to get them there, even if it means you have to cut some corners in the process. And it's sad to see that that's the direction the medical system is going. And this is, again, my subjective viewpoint that has not been doing this for very long. It's sad to see that that's kind of the direction I see it going. but it was very refreshing to see that pediatrics was the opposite. I can think of a few times where it took us 20 minutes to get an IV, and everybody was understanding about it. The surgeon was in there trying to kind of help us out where they could. I mean, the anesthesiologist was in there helping us. I mean, it was really nice to get to see that. It was a great environment to learn in as well. Again, I was worried that I would kind of be thrown to the wolves in all of this, and that my life would be turned upside down. I wouldn't know anything, and it would just be this insane drinking from a fire hose, hang on if you can. But it wasn't. I did have days that were like that, specifically dental days. Not really dental days, but if we were at the outpatient center and we were doing BMTs, T&As, those days were quick. There was turn and burn, try to chart, catch up if you can. Those days were tough, but I feel like I learned a lot there. I learned how to manage patient as the priority, learned how to get better about charting. I'm not good yet, but I got better there. I learned patient-centered care. I got really good at IVs while I was there. I think I got north of 150 IVs when I was there in those 2 months, which was crazy. Learned a lot about inhalational induction, used Precedex like they were paying me to do it. I mean, it was really cool to get to see all of that stuff. The one thing I never got used to in pediatrics, you're gonna have to hear me out on this one because it's kind of dark, but you'll see where I'm going with this. In adult world, if I see a patient come in who is willingly morbidly obese in terms of they don't have any underlying, thyroid issues, etc., it is a choice in terms of diet. Let's say they've smoked their whole life, they have taken every risk possible, they don't take care of themselves in any capacity, they're off their medication, they're non-compliant on CPAP, any number of things. And let's say they present for a lap chole or something like that. I can understand what decisions led to that. And I understand that this patient is a higher risk because of their choices. Had this individual chosen to exercise, chosen to diet, chosen to be compliant on blood pressure medication and followed recommendations, they would be in a much better place, in my opinion, medically. If you flip that and look at the pediatric sector, if I was doing, let's say, the same thing, a lap chole on a 6-year-old, there's not enough time in my head for that 6-year-old to make the decisions to lead them to that. They didn't have the choice. And that was the hardest part for me, is the vast majority of these kids did not make decisions that led them to be in the hospital. They did not mistreat their bodies. They haven't taken these huge risks. It's either the parents or it's genetics that have led them to being on this OR table today. And that was very hard for me, in particular when it came to cancer, tumor removals, and various other genetic abnormalities. Those were the really hard ones for me. In adults, I got very good at kind of parsing out, hey, you know what, if they had taken care of themselves and if they had been compliant on these medications, then we wouldn't need to do a thyroidectomy, or we wouldn't need to, take out their appendix. Well, maybe not appendix, but I think you see where I'm going with that. It was very hard to see that in pediatrics. I mean, I vividly remember one of my last cases at this site. It was, they were 12-ish years old, they were preteen, and they had a tumor that was growing near their pituitary gland. And this procedure was a craniotomy for tumor debulking. And it was tragic to see, because I would hear all of the things that this child was doing outside, living a normal life, being involved in sports, going hiking, and, talking to them beforehand. And then the frequent headaches started, the signs were there. They did the CTs, the MRIs, the whole 9 yards, and then now they're here. I struggled with those cases the most, and this individual's was probably my most striking. I vividly remember the depth of this case and what it meant. And then as we approached the tumor, I say we, it's obviously the surgeon over there. But as we approached the tumor, I was paying attention to urine output and saw that this individual was making an excessive amount of urine. And it's just, I notified my preceptor, we notified our attending, and then we ended up notifying the surgery because we're working near the pituitary and this read exactly like, diabetes insipidus. And sure enough, they ended up calling off continuing the case. And that was, I remember the surgeon saying that for this type of case, if you don't pull out 100%, if you stop at say 75 or 50%, it's not a curative treatment. It's not a solution. It's a temporizing measure to help the child. And so it is and was very hard for me to know that because of what I saw, we stopped. And I've carried guilt about that because, again, excuse the dogs. Those are upstairs neighbors. But because of what I saw, it meant that we couldn't get 100% of the tumor out. And on face value, I recognized that it was, in a sense, not my decision to make. I just provided more information to those around me, including the surgeon. And the surgeon was ultimately the one who weighed the risk-benefit and ultimately decided it would be better to leave it, the tumor, in its partially debulked state. But I just can't help but feel like, because of me, this child is kind of still on the clock. And that's something I still think about, even today. And I may never know how they ended up where they're at now. I have no idea. I can't go back into the health system and look. I don't remember their name. I mean, I can see their face, and it's tough, but, there's nothing I can do about that. But it's tough. That was the toughest thing for me. There's always, people in medicine sometimes talk about, like, the innocence and how the innocence makes it harder. I remember doing a case where this child was very rough off, and the anesthesiologist said, he went to update the parents and kind of talk to them about how things had gone, what was going on with the patient. And he said, and of course the parents were nice about it. And the way he said it, you could tell it just made it that much harder. That sometimes we would look for ways to distance ourselves from the reality. If the parent was a jerk, or if the kid was throwing tantrums the whole time, we could kind of distance ourselves from the reality of it. And it was very hard when we had to face that reality full force. There was no escaping it sometimes. Sometimes the parents were fantastic, took the child to every single doctor's appointment, followed recommendations 100%. They did everything they could. and it just wouldn't work out. And those were hard. Those were very hard. I still think about those. I mean, pretty early on, I saw, it was effectively a code on a very young child. It wasn't full-blown code, but it was grabbing the card, and it was frantic. 4 anesthesiologists in the room, all working. And, you know, this was pretty early on. I mean, I knew enough, but I didn't know anything. And I was trying to help out where I could and just do what I could, and that was tough to see and feel so helpless. I mean, I still think about that kid too. There's a view of him that I still think about. And I just wonder. You know, it's also awful when there's a frequent flyer who'd come through. Frequent flyer is just a term for somebody or a patient who comes through the system a lot and the staff is familiar with them. It's not a derogatory term. I mean, there's this one kid, I mean, his parents were hardly around, and I mean, he didn't deserve that. And the poor kid didn't know. I mean, he was very special needs and very bad off, but he was getting progressively better. I mean, I also heard through word of mouth that his parents said that if it was his time, it was his time, and they wouldn't fight it, and that they were okay with that. I won't chase that rabbit hole too far, but sorry. That was very heartbreaking. And for as much as I resented the parents for saying that, I understood. I understood. It did not make it easier, and you could argue if it made it right or wrong. But I understood. And I hate that I understood. And I fully understand that you can't form an opinion on it because you have no idea this patient, who they are, what they were going through. But I'll leave it at that. So that was the heartbreaking side of this. The heartbreaking side of pediatrics. The rewarding side was seeing the progress and knowing how far some of these kids have come. And I won't lie, a lot of these procedures were routine. You know, tonsils and adenoids, ear tubes, circumcisions, things like that. Sort of these bread and butter cases, if you would. And it was, you know, good to see healthy, happy kids come through. But man, when it was heartbreaking, it was heartbreaking. It was one of my more interesting rotations so far, even including the February and March rotation, because it was so different. ET tubes, as an adult, we kind of just eyeball them and pick a number. Odds are it's gonna be a 7, 7.5, or an 8, and you just kind of pick between those three based off of gut instinct. Some people still try to size them properly, but 9 times out of 10, it's just one of those three. You know, a Mac 3 or a Mac 4, you know, a Miller 3 blade. I mean, you kind of just get into a rhythm. Is it a 90 or the 100 oral airway? But for pediatrics, you actually have to put in conscious thought for their age, their weight, their height, and figure out all of these things and pick a blade size. And which blade do you want? Do you want a Miller? Do you want a Phillips? Do you want a Wiss? Do you want a Mac? And then the size of that, along with the tube size, is it cuffed, is it uncuffed? You have to do the LMA by weight sizing. You have to do the ET tube depth by height. And go through this whole laundry list of things before you've even seen the patient. Whereas in an adult, you can kind of look and be like, female 5'5", 7.0 tube Mac 3 blade, 90 oral airway, just like that. But for a pediatric patient, it's like, okay, they're 3 years old. How much do they weigh? How tall are they? And then you have to go through and like, okay, well, they're at their 99th percentile for growth, so they're doing, you know, and then figure it out from there. And then you have to make judgment calls, and it was very hard to get a feel for that initially. It probably took a good month for me to get better about just visual sizing, like looking at a kid and being like, okay, yeah, I could probably do this. I'm gonna get better about it. I was also very bad at intubations initially. Not a big fan of straight blades, so like the Wiss, Phillips, or Millers. I struggled for a while there, and then I was in an ENT room. We were doing T&Days. It was at the outpatient surgery center, and you know, those ENT guys, this is, you know, the oropharynx, nasopharynx, and pharyngeal spaces, you know, those are their bread and butter, like they know it. So one of them gave me advice and said, look, if you're lifting too hard, you're doing it wrong. For these guys, you have to rely way more on technique and really get to the side and get a better view. And I was used to adults. I'd been kind of thrown to the wolves, and I got by with just brute force in terms of just, all right, we're gonna lift really hard and we're gonna get a good view, obviously trying to use good technique, but I didn't know what good technique was at the time because I wasn't being shown that at my first rotation. So then I talked through it with my preceptor, I got feedback from the doc, the surgeon, and then I tried implementing their techniques, particularly for straight blades, and I was getting views like I'd never gotten before. I mean, it was like a light bulb went off. And all of a sudden I was getting really good at it. And then towards the end of the rotation, if I couldn't get it, I knew that it would take my preceptor a couple tries. And that was a huge confidence booster because in my last couple weeks, I had a few difficult ones. There was one that I was very surprised I got. And there was one I just could not even visualize. So I passed it off to my preceptor. They couldn't get it, passed it off to the doc, and he struggled. And he got it after a few minutes, you know, intermittent with bagging. But it was very good to know, and very confidence boosting, if you would, that I got comfortable enough where I knew if I missed it, it was gonna take them some tries too. I didn't quite get there with IVs, I got close. But some of those nurses there, dude, they can put one into anything. I mean, they could probably find a vein in my lip if they tried. I mean, it's insane how good they are. And I was getting better. I would say I was good. I wasn't great, but I was good. I mean, putting in 100, you get there eventually, but some of these kids, some of the chubbier kids and like the 6 months old, you know, where they're still hitting their growth milestones and things like that. They've still got some chubby hands. And a lot of that just kind of comes down to instinct and trying to find. I had been used to adults where you look for, you know, the plump vein, you look for like discoloration, things like that. Whereas kids, we call them shadows. You find a shadow and you go fishing. I mean, it's small stuff we're aiming for. But I got a lot better at it, which was very nice to hear. And it paid off a lot in adult land too, because I'm still pretty good at them. Coming from doing 6 months old, getting a 60-year-old who's got a juicer, my current record is I put a 16 in the back of somebody's hand. That was 2 weeks ago. I did not think I was gonna get that one, but I did, and I can tell that story later on, if I can remember to. If I forget, remind me. But yeah, I got really good at IVs. I got a lot more precise with my laryngoscopy. I got very good at taking it easy, going slow, and doing a lot more things gently. In terms of cases, I did see some crazy things, like the craniotomy. It didn't do any hearts while I was there. That was a dedicated team, and it was not with people who I could go with, because again, a specialized division. Let me just kind of flip through real quick. I did keep track of everything, as I kind of always tend to. A lot of dentals, so I did get a good bit of nasal intubations and all of that kind of stuff, which was pretty cool. Circumcisions, that's something we didn't see in adults too much. A lot of BMTs, so just masking them down and going through all of those. Those are some of my youngest patients. Quite a few hernias, couple one NUS bar placement, which was pretty interesting. So if you have, I think it's called pectus excavatus, which if you've ever seen somebody who looks like you have their sternum and you just kind of push it back a few inches and it kind of like bows in, the NUS bar is a procedure that can help correct that because it kind of brings the wall back up. Pretty invasive, but pretty cool to see. I did see gynecomastia correction on a patient. That one was very interesting and pretty involved. This surgeon is kind of known for being slow, but again, going back to kind of the patient-centered care, once this individual was asleep, we kind of collectively all examined the anatomy, and the surgeon, we were there for a different procedure actually, and the surgeon took a look and was like, that's gynecomastia. And so he was kind of looking at it, getting a feel for it, and figuring out how this growth would develop. And one of the most interesting things to happen, it's kind of funny, this surgeon was, again, I don't use names, I try not to use descriptors, but this surgeon, if I had to eyeball him for age, I'd put him at 50. He literally looked around the room, he saw me, and mind you, he's seeing, this, because I have my mask on, so he's looking at this. And he's like, you're young. If you were this kid's age, what would you want me to do? Like, this is not my call, buddy. I got the tube in, and he's asleep and happy. That's my job. But he singled me out because I'm the youngest guy in the room. Everybody else was either female or over 50. And so he's like, what would you want me to do? And I thought back, okay, when I was this kid's age, that's locker room age. He's got these other things going on, and he's not quite through puberty visually. I'm thinking, if he starts to put on muscle, then at that point, that's locker room age. I personally would have been embarrassed, and I would have been self-conscious about it, because kids that age don't hold back, especially in a locker room setting where it's unsupervised. Good Lord. So I told him, I said, if this was me, and let's remember for a minute that this is not me on the table. If this was me, I would say, I'm already asleep, I'm already here, let's just go ahead and get this taken care of. I've already taken time off school, I already am ready for the recovery. Let's just go ahead and get this over with and done, right? Because I would be self-conscious about it in a locker room setting, something like that. That's my take on this. Now again, that's speaking for me. I can't speak for him, but you asked me, and that's what I would say. He's like, okay. And he pointed at my preceptor, who is a mother, a mother of a young boy. You, if this was your son, what would you say? And she said, yeah, he's already off of school. He's already planning on all of this. If he wants it fixed later, he's got to come back, get off school again, go through the whole recovery process all over again. I would say, let's do it. He kind of sighed. He is a surgeon, kind of sighed and went, I'm going to go talk to the family. And he left, went and talked to the family. He was out there for like a good 30 minutes. Comes back and he's like, okay, they agreed. They said, let's go ahead and do it. So he went in and removed the gynecomastia. It added like 4 hours to the procedure. But again, that kind of goes back to the patient-centered care that I hadn't seen before. I mean, if this was an adult, I mean, they would have just been like, oh no, I'm scheduled, this case is ending at 2. We're just gonna finish it. But that was something I had not seen before, and I thought that was really cool. That they were just very patient-centered. But I had never been singled out like that before. I thought that was kind of funny, just the way it was. What would you want done? Like, buddy, I'm not on the table. So that was really funny. A good bit of ortho at this place. You know, kids break bones, things like that. Fall, broke their wrist, broken leg, stuff like that. Hernias, yep. A couple big spines, not too many. I think I did 2 or 3 big spines there, scoliosis corrections. Those were longer cases. Pretty cool. Good bit of hernia repairs. I'm just scrolling through what I've done. A good bit of GI, EGDs, colonoscopies, things like that. Again, those were kind of hard because, you know, it's not the kid's fault. Yeah, the neuro stuff, some of the neuro stuff, man, that was crazy. The craniotomies, the VP shunts. I mean, I helped, I can see the preceptor in my head. She's actually a CRMA. We did a VP shunt on a 4-month-old. That was wild. I mean, just, it might have actually been a VP shunt revision, but either way, one of the crazier cases I've done just in terms of on paper, like, good Lord. Saw some crazy things, did some crazy things. Overall, I would say it was a great rotation. I'd go so far as to say it was an excellent rotation. It humanized a lot of things for me. And some of it I wish it wasn't humanized. I wish I could just file it away in my brain and forget about it. But to that end, it also just brought it all back. It's like, this is why we're clocking into work. It did make it a lot easier to clock in on those days. But man, those tough days were awful. Not awful because of preceptor, not awful because of, I was there till 8 o'clock. Just emotionally draining on some days. But somebody's got to do it. And I have nothing but respect for them for feeling that calling. So, I think I've done enough talking. That's how my pediatric rotation went. Dog's drinking water, of course. Anyway, sorry about that cut. I was gonna go ahead and wrap this video up here. I'm at the end of it. I did just want to mention, kind of shout out, I did meet somebody at my most recent rotation, my February and March rotation. They're starting Emory soon, so I'm really happy for them. I do my best to not talk about people in any way that could, I don't know who wants to be talked about, who doesn't want to be talked about, and I don't have permission. Just know I know exactly who you are, remember your name and everything. And you are still free to text me, by the way. But yeah, it kind of reaffirmed why I like doing this, because they found out I was rotating there as an AA student, asked me a bunch of questions, and it was kind of hard because I would have to be between cases and they would have to not be busy. But it was still really cool to, you know, help out and answer questions where I could. And I know that they watch the videos because they've pointed out some funny things here and there. I just thought that was awesome. Reaffirmed why I like making these videos. So, special shout out to you, my friend. Feel free to reach out. Again, I'm sorry I told you the video would be coming out sooner and it hasn't, but I'll explain why in the next video, or you can just shoot me a text and I'll explain it. So anyways, I'll go ahead and wrap this video up here. The next one should be out sooner than 3 months from now. Things are starting to wind, not necessarily wind down, but things are moving kind of quick. So I'll go ahead and end this video here. Thank you for watching. I wish you nothing but the best. If you have any questions, please feel free to reach out. And other than that, I'll see you in the next one. Take care.